I think we have about 113 students here. Let's, yeah, we'll wait for another couple of minutes because today we are going to, so today's lecture is on therapeutics of urine tract infections. So, so I'm not going to give you a lot of details about urine tract infection theoretical aspects. This is mainly on management. So you all have already learned urine tract infections in the nephrology module. So it's more of an application of your knowledge here. So based on some cases, and as I told you initially, you can indicate your answers through a poll on the screen, right? So I will let you know when to start polling. So first case, a 35-year-old female presents with frequency of urine and dysuria for 2 days. She has no fever, nausea or vomiting, no significant past medical history. What is the best next step in her management? So it's a very straightforward case. So response A, request a urine full report and treat if it has pus cells more than 10 for high power field. That's the first response. So one of these 5 is correct. So you have to select the most correct answer. Second one is request a urine culture and treat if it is positive. C is give oral nitrofurantoin 50 milligram 6 hourly for 5 days. D is give oral piperacillin 500 milligram twice daily for 5 days. E is to encourage her to drink more fluids and observe. So we'll open the poll now. So you can, I'll give you some time for you to this we are doing for the first time. Let's see how it works. Right, can you see the poll?
Yes, sir.
Right, okay. So you can, I'll give you about 15 seconds or 20 seconds to select the answer. Let's say 30 seconds. I'll give you some more time until we get substantial number. All of you should give your response because it's a good opportunity to, you know, show what you know. Okay, so we'll stop it there. So both about 80% have voted. So we'll close the poll now. Right. Okay, so I'm now going to share the results with you, how each of you have voted for each response. So, right. So can you see the results?
Yes, sir.
Right. So basically, most of you feel the correct answer is response A. Just that you have to. So basically, the case highlights that it's a case of simple cystitis in a premenopausal female. So it's a very common situation. Patient coming with urine dysuria and frequency. So these are classic symptoms of cystitis. And she doesn't have any other comorbidities, no complications. So it's a straightforward, suggests a straightforward case of simple cystitis or lower UTI. So the key question here is how we are going to manage this patient. So what you need to understand is these are this is a very common condition which most of the females are experiencing. So much so it's like a straightforward diagnosis. So basically, you don't need to rely on a urine culture or even a urine full report, as for that matter, to make your diagnosis. So it's a more of a clinical diagnosis. So therefore, answers A and B are wrong. So you don't need to do an investigation. You can just base on your diagnosis based on your clinical features. So a simple cystitis diagnosis of simple cystitis could be made even without any further investigation. So A and B are wrong. So you don't need to do those tests. And obviously then we need to decide with what we need to do for the patient. So there are three options. One is to two of them involves giving antibiotics, and the other one is to just encourage her to drink more fluids and observe. Obviously that's not a good option because the patient is obviously symptomatic and there's clearly some signs of infection. So just observation is not going to be adequate. So answer E is also incorrect. So you realize that the majority have responded to these three responses. So you see how sometimes tricky the questions are. So it's between C and D. So both, so obviously now we have decided we need to give antibiotics for this patient. So it's between oral nitrofurantoin or ciprofloxacin. Both of them are okay in this type of patients for the treatment of cystitis. Both are effective. However, when you look at the duration of treatment, there's a slight difference between the two drugs. If you give oral nitrofurantoin, it's a fairly mild drug. It's also called a urinary antiseptic. Basically, the drug gets concentrated in the urine, so it acts on the bladder. So usually it needs about 5 days of treatment. Whereas ciprofloxacin, it's a strong antibiotic. It works through the blood. Therefore, you don't need to give for 5 days. Generally, 3 days of treatment for simple cystitis is adequate. So correct answer is C. So I'll stop sharing the polls. So right. So that is the correct answer. Answer C. So moving on to a bit of nomenclature about urinary tract infections. I think these terms, although it's a therapeutic lecture, I think we have to be very clear about what these terminologies mean. So lower urinary tract infection means it's either infection of the bladder, which is also called cystitis, or it could be the infection of the urethra, which is also called urethritis, or involvement of the prostate, or prostatitis is called prostatitis. So that is what is meant by lower urinary tract infection. When you say upper urinary tract infection, just generally it means that the infection is involving the kidney. So any infection involving the kidney, such as pyelonephritis, intrarenal abscesses, or perinephric abscesses, are collectively considered as upper urinary tract infections. Then cystitis, as I told you, is involvement of the bladder. So this particular patient also had cystitis. Then there's this terminology called complicated and uncomplicated UTI. So basically, different books or people, clinicians have different interpretations of these terms. But generally, what is meant by uncomplicated urinary tract infection is generally somebody who is getting an infection in the absence of any other kind of risk factors or any other underlying anatomical abnormalities in the urinary tract. In other words, if the urinary tract is functionally normal, if you get infection, that is called an uncomplicated UTI. Sometimes people say that, classically, if a female get a cystitis in the absence of any other risk factors or any other underlying problems, that is called a simple cystitis, simple or uncomplicated UTI. And anybody else who gets an infection apart from a premenopausal female with a normal urinary tract is called a complicated UTI. So there is a slight kind of issue with the terminology, but generally what you need to understand is if a healthy person, if somebody otherwise healthy gets a urinary tract infection, it's called uncomplicated UTI, whereas a complicated UTI is generally somebody getting a urinary tract infection in the presence of any other anatomical or functional abnormality in the urinary tract, or any other risk factors like immunocompromised state, multi-drug resistant bacteria, or any other issue which might complicate the infection. If somebody has any of those, then it is called a complicated UTI. Then pyelonephritis, as you know, is a classic term used for infection of the kidney. And it's classically associated with fever and flank pain. And there's this entity called asymptomatic bacteria, where the patient has presence of organisms in the urine run by the cultures, but they don't have symptoms. So this is called asymptomatic bacteria. So these are just some clinical terminology will be using throughout our presentation. So again, going back to uncomplicated or simple cystitis, which what this patient had, it usually occurs, it is by definition occurs in a healthy adult woman who is a premenopausal female above the age of 12, but before the premenopause, and who's non-pregnant, and who doesn't have classic symptoms of upper urinary tract involvement, such as fever, nausea, vomiting, or flank pain. So anybody with these symptoms, if they have either fever, nausea, vomiting, or flank pain, that suggests that the urinary tract infection is not confined to the bladder. It is probably going above the bladder, involving the kidney as well. And usually diagnosis is not essential. Just the clinical diagnosis is enough, but sometimes you would want to do a dipstick analysis, and that would be enough. You know that there are dipsticks that can be used to diagnose urinary tract infections. There you have certain strips which has, such as nitrate strip and things like that, leukocyte esterase strip. So they can get positive when you put the stick into the urine, and that itself is an indication of infection. So that alone will be enough, but even without that, you can start treating the patient as in this particular case. And the treatment I will go into detail in the next slide. So basically the commonest risk factor for uncomplicated UTI is sexual intercourse. So usually it happens in sexually active females. So that is one thing you need to remember. So when you go to treatment, usually treatment is with oral antibiotics given for a short period. And you can use any of these antibiotics, nitrofurantoin, either 100 milligram 12 hourly or 50 milligram 6 hourly for 5 days. Then co-trimethoxazole, which is a combination of trimethoprim and sulfamethoxazole, can be given 12 hourly for 3 days. Then co-amoxiclav, or otherwise known as amoxicillin clavulinate, can be given 12 hourly for 3 days. Ciprofloxacin given as a dose of 250 milligram 12 hourly for 3 days. So basically, strong antibiotics, you need only 3 days of treatment, whereas nitrofurantoin you give for 5 days. Okay. Time for the next case, right? So this is the case number 2. A 54-year-old female with type 2 diabetes is admitted with fever with chills, vomiting, and loin pain for 2 days. So obviously, you know, this is not a simple UTI. This patient has got a complicated UTI, possibly involving the kidney. So it's probably a pyelonephritis. Which of the following statements is correct regarding her management? So we'll open the poll. So you can start polling. Case number 2. Okay, so I'll read through it while you enter your responses. Response A is a urine culture is not mandatory prior to initiation of treatment. Response B, an ultrasound scan KUB should be performed to confirm the diagnosis. I think some parts of the question is missing here. So you can you see the question on the slide also?
Yes, sir.
Yeah, so you can read it through on the slide as well. B is an ultrasound scan KUB should be performed to confirm the diagnosis. C is nitrofurantoin could be used in the treatment if the organism is sensitive to the drug. D is a third generation cephalosporin is preferred antibiotic if the infecting organism produces extended spectrum beta lactamase. E is changing the treatment to a sensitive oral antibiotic is acceptable if the symptoms improve with an IV antibiotic. Okay, it's not straightforward. So just take your time, start voting. Could you all mute your mics, please, because some of the are them on. Okay, I think we'll stop it there because I think most of you all have voted. So we'll end the poll. Right, and I'll share the results. Okay, so basically, so it's majority feel that it's either D or E, and some of you feel it's A, B, or C. So going by the last question, I think last case scenario, you cannot predict which one is correct because last time you answered all what you have answered, majority were wrong. So let's see. So so obviously, as I discussed, as I explained to you initially, this patient probably has a complicated UTI because this patient has got evidence of upper urinary tract involvement as evidenced by presence of fever and vomiting and loin pain. So clearly this is not a simple cystitis, and this needs urgent treatment. And question number response A is a urine culture is not mandatory prior to initiation of treatment. This is wrong because generally you would want to get a urine culture in these patients because these are complicated cases. So obviously you need to know the organism which the infection is being caused by, so that you can use the appropriate antibiotic, because these are usually problematic organisms that causes these infections, complicated infections, as I will tell you in the presentation later on. So response A is incorrect. You have to always get a urine culture in these patients. B, an ultrasound scan KV should be performed to confirm the diagnosis, is also incorrect because most people think that pyelonephritis is an ultrasound scan diagnosis. It is not. It's a clinical diagnosis. So this patient has classic symptoms of pyelonephritis with fever, vomiting, and loin pain. And ultrasound appearance does not really help or tell us or exclude the diagnosis. So that is not relevant. But sometimes you can use ultrasound scan to see whether there are any other anatomical problems, obstruction of the urinary tract and things like that. But the question here is, response statement says it's used to confirm the diagnosis. So confirm the diagnosis, you don't need an ultrasound scan. So that is also wrong. Response C, nitrofuran could be used in the treatment of if the organism is sensitive to the drug, is also false because I told you that nitrofurantoin is a urinary antiseptic. It does not get into the blood, and it only gets concentrated in the urine, and it is effective in the bladder. So if you have a cystitis, you can treat, you can use nitrofurantoin, but nitrofurantoin does not get into the blood. So pyelonephritis, as you know, it's a renal parenchymal disease. So where the drug has to be in the blood to reach the target of the infection. So so therefore nitrofurantoin should be not used for pyelonephritis, and also it should not be used for patients with reduced GFR, because as you know, the drug should enter the urine for it to work. So if there's reduction in GFR, you don't produce much urine, and the drug cannot enter the urine. So therefore, you can't use it. So that's another important thing you need to remember. It should not be used in pyelonephritis, and it should not be used in when the patients have low eGFR. So it's between D and E. So third generation cephalosporins are more or less the first line, one of the first line drugs that we use for management of complicated UTIs, and it's an intravenous preparation. So it's ideal for treating patients with pyelonephritis and also complicated urinary tract infections. However, there's another clause saying that if the infective organism produces extended spectrum beta-lactamase. So beta-lactamase is an enzyme that is produced by some bacteria, and what happens is the beta-lactam antibiotics don't work because the beta-lactamase can destroy the beta-lactam ring. So these antibiotics won't be effective. So what are the beta-lactam ring containing antibiotics? These are the penicillins and the cephalosporins. So therefore, they won't. Work against these enzyme producing bacteria. So therefore, you can't use a third generation cephalosporin in this situation. So the answer is E. So you can change the treatment if you start the treatment with a IV antibiotic. You can always change once the culture and antibiotic sensitivity report comes. If you have an antibiotic, oral antibiotics to which the organism is sensitive, and if the patient has already clinically responded, if the symptoms have improved, especially fever, then you can always change the antibiotic to an oral antibiotic, because there's no difference between oral and IV antibiotic if the patient can take the drug. And if they don't have vomiting and things like that, so that the patient is unable to take the oral drug. So therefore, the answer is E. I will halfway through, I will give you some time to ask questions, so that you all can have, if there are any questions, you can ask me. But for the time being, we'll just move on. So we'll go to the presentation. So the correct answer is E. Changing the treatment to a sensitive oral antibiotic once the symptoms improve is acceptable. So that is the answer. I think most of you have got the answer correct in this scenario. Okay, case number 3. A 62-year-old female is admitted with fever with chills and loin pain. Despite being treated with IV, I think some of you are still keeping the mics on. Despite being treated with IV ceftriaxone 1 gram daily, the organism is sensitive on the ABST. So basically, they have done a culture and ABST, and the organism has been shown to be sensitive to this particular drug. So despite being treated with this particular sensitive medication, the patient continues to have loin pain and fever. So clinically, the patient seems to be not improving. What is the most appropriate next step? So we'll start the poll. So the responses, response A, whether you want to increase the dose and frequency of IV ceftriaxone. You know that it's patient is sensitive to this particular drug. Or whether you want to change the antibiotic to a more broad spectrum antibiotic like IV meropenem. Or whether you want to repeat the urine and blood cultures to decide on a change in antibiotic. Or whether you want to perform an ultrasound scan KUB. Or whether you want to make inquiries about the quality of the antibiotics used. So take your time, and once it hits about 80% response, I will stop the poll. I'll give you 10 seconds more. Okay, we'll stop the polling. Right, so I'll share the results. Okay, fine. So, yeah, so there seems to be kind of more or less equal distribution, and most people think the answer is D. Let's see, let's check one by one. So, some people feel that increasing the dose and the frequency of IV ceftriaxone would be useful. I think before that, we'll get the correct answer. I think the most important thing when somebody has got loin pain, fever, chills, and which is not responding to IV antibiotics despite it, the organism being sensitive to the antibiotic, the first thing you have to think is, why is the patient not improving? I think one of the reasons why patients not improve is because there are other complications they develop due to this infection. So this patient has got pyelonephritis. So what are the other complications which can develop in these patients? The patient could develop a intra renal abscess, or she can develop a perinephric abscess. So that those are some situations where the patients don't improve. And also sometimes the patient can have an obstructed system, causing obstruction to the urinary tract, and therefore the infective organism cannot be eliminated. So it's a good kind of medium for the organisms to grow, and antibiotics usually don't reach these collections. So all these complications can be detected by doing a simple ultrasound scan. So that is the correct answer. So majority of you have got the correct answer. At least about half of the people. And now we go to the other responses. Increasing the dose and frequency of IV ceftriaxone is not really going to be useful, because patient usually ceftriaxone 1 gram daily is a fairly sufficient dose for a fairly older female who doesn't have probably much muscle mass anyway. So I think increasing the dose in this situation is not going to make much of a difference. Changing the antibiotic to a broader spectrum antibiotic is also sometimes considered, but in this situation the key thing is that the organism is sensitive to the antibiotic. So changing to another antibiotic in this situation is unlikely to make much of a difference, because if the patient is going to respond to antibiotic, this antibiotic itself is enough. Then response C, repeating urine and blood cultures are also sometimes considered, especially if the original culture has not grown an organism. That is when we want to repeat cultures to see whether there is any organism coming out in the urine or blood. But if you have already know that the patient has got a particular organism, and we know the antibiotic sensitivity pattern, doing another culture now is not going to be that useful. And only thing is, I think some of you might think that the patient may have now developed a resistance, but this is too early. Within few days you can't develop resistance to a drug which is previously sensitive. So C is also wrong. And yeah, sub-quality drugs sometimes are being used, especially there have been incidents in papers also where people have complained that certain drugs are not working and they are of sub-therapeutic quality. But usually that is not the case in most of the situations, and that is something that you have to consider if you get repeated situations where the drugs don't seem to work. In which case you have to make inquiries to the quality of blood, but usually it's not the case in the hospital. So the correct answer is D. So that's the answer that I wanted. So performing ultrasound scan KVB is the correct answer. Right. So we'll do a bit of some teaching around these two cases. So obviously this patient had was a complicated UTI. So especially in the patients who have not only cystitis, who have upper urinary tract infections, they usually when it's called complicated, they usually have other issues like such as anatomical abnormalities, obstruction. They may have immunocompromised states such as diabetes, or maybe on some immunocompromised medications. And there are a whole heap of situations where you can, you are at a higher risk of developing infections, and even if infections develop, you can develop complications. So these are all collectively considered as complicated UTIs. And these situations, these patients, obviously at the outset, when you take the history, you know that these patients are at high risk, especially somebody with diabetes or immunocompromised patient with other past history of infections and all that. So it's essential, as I told you earlier, that you need to investigate these patients carefully, especially doing a urine culture, urine analysis, and also other investigations, including imaging. Those are important in these situations, as I discussed in the case. And when it comes to treatment, next slide. Before that, as I told you in my case, there is a difference in the spectrum of microorganisms causing complicated and uncomplicated UTIs. If you consider the uncomplicated UTIs, usually the commonest organisms are E. coli under the gram-negative category, and in the gram-positive group, coagulase-negative staphylococci. So, but even among these two categories, by far the commonest organism is E. coli. But when you consider complicated UTI, the spectrum is much different. Where these other organisms, Proteus, Klebsiella, Enterobacter, Pseudomonas, they also come into the picture. And also other gram-positive organisms like Enterococci, Group B Streptococci, or Staphylococcus aureus, they are also involved. So there's no hard, that's why it's important to do a culture in patients with complicated UTI, because we don't know which organism is involved. Whereas in the uncomplicated cystitis, we know most of the time it's E. coli, or if at all, if it is something else, it has to be something like a coagulase-negative staph. So therefore you need to remember this slide, that this is the reason why you need to do a culture in the patients with complicated UTI. And yeah, I think when it comes to treatment, most of the time you need to give a broad spectrum intravenous antibiotic in the case of a complicated UTI. But again, as in the case, you can change to a oral antibiotic if the patient is sensitive once the ABST arrives, if the patient clinically responds. And also the important thing is you need to consider imaging of the patient, if the patient, especially if the patient does not respond, or the response is late to antibiotics. Okay, right. So before moving on to the next case, I will give you about 5 minutes for you to ask any questions from the first 3 cases. So can you just send me some questions? Already one question has come. Sir, in case number 3, what is the place for hospital-acquired infections in if the case is not improving? Yeah, so what you are saying is that sometimes when the patient is not responding, whether this is some, so what you are thinking is there is some other infection. Yeah, so you can have hospital-acquired infections, but usually somebody coming with the infection to the hospital and who's on treatment for that particular condition, if the patient's that particular condition is not improving, first thing you have to think of the poor response to treatment rather than another infection. Sometimes what happens is patients do improve initially with antibiotics, but after some time the fever settles and the patient clinically improves, and after some time again the fever starts. In that situation, you can think of a hospital-acquired infection, whether the initial infection is now settling, but there's another infection coming on top. So that is the only situation where you have to think of a hospital-acquired infection. So there's another question. If we start treating empirically and patient is responding well, we don't have to change antibiotic according to ABST result, isn't it? Yeah. Usually it doesn't happen. Usually the patients, usually once you start antibiotics with usually with one antibiotic and the patient has clinically responded, you don't need to change. unless you have initially started with a broad spectrum antibiotic, because you do sometimes, especially when the patient is very ill, you might want to start with a stronger antibiotic to make sure that that the drug acts quickly. So you want to cover most of the organisms. But when the culture report comes, ABSC, sometimes the patient might be sensitive to even a milder antibiotic. So in that situation, even if the patient responded, you want to change to a milder antibiotic. In pyelonephritis, IV antibiotics are not always first-line treatment. Yes, pyelonephritis per se is not an indication for IV antibiotic. The patient, especially if the patient doesn't have vomiting, and the patient is clinically well and can be otherwise okay, you can start oral antibiotics. But our setting, usually the patient who comes, they are quite ill, and we don't sometimes want to take a chance, and we start the patients on IV antibiotics at the outset, and if the patient improve within 24 to 48 hours, then they can be changed to oral. So although you can give oral antibiotics, generally we don't do that. Next question: why does fever and vomiting occur in upper UTI but not in lower UTI? That is because of the amount of inflammatory mediators that are being released. So I don't know the exact answer for this. This is more of a pathophysiological kind of a question, but it's more that in case of cystitis, it just involves more like the superficial epithelium of the bladder, whereas in pyelonephritis, it involves the parenchyma of the kidney. So it's more likely to involve a lot of inflammatory cells and mediators, and that is why they get a lot of systemic effects. If a man develops UTI, which is a complicated UTI, does he need IV antibiotic or is only pyelonephritis? Yeah, so if a man develops a UTI, depending on which book you read, sometimes it's considered a complicated UTI, sometimes it's uncomplicated. Anyway, generally, I don't think there's any difference between a man and woman when it comes to treatment. If it's a simple urinary tract infection, in the sense there are no evidence of upper tract involvement, you can treat with oral antibiotics. You don't need to give IV. Then do we need to treat all the simple cystitis? Yes, we need to treat, because simple cystitis is a symptomatic disease due to an infection caused by an organism, and that has to be treated with an antibiotic. So there's no question of treating the patient. In case 3, if ultrasound scan shows it has become complicated with an abscess, how do we change the antibiotic course? Should we drain it always? Yeah, sometimes if the abscess is small, you can just give IV antibiotics, it resolves. But sometimes, so you need to keep on monitoring clinical response as well as the repeated imaging to see whether the size of the abscess, does it reduce. And most of the time, actually, you don't need drainage. Rarely only you need drainage. Most of the time, antibiotics work. This is regarding a previous lecture. Is there a need to increase the frequency? I think previous lectures, I think we should not ask here. If I have time, we will discuss it later at the end of the lecture. Is the urine culture result too late and unreliable in NHSL labs? Yeah, it's just a non-specific question, whether it's not really relevant to this particular teaching session, but yeah, sometimes depending on the hospital and all that, you might not get accurate results. And we used to have problems in the past where we don't get any cultures positive, and that may be sometimes not because of the problem in the lab, but maybe because patients usually come late. Because they are being given drugs by GPs, and they sometimes go and take over-the-counter medications from the pharmacies, and because of that, the cultures become negative. So that is why the cultures don't show anything. But increasingly, we are seeing more and more positive results. So I think now, I think whatever the issues that were there in the hospital has been sorted. In case one, if it was uncomplicated bacteriuria, is observing and hydration possible? No, it's not possible. So as I told you, if the patient has symptoms, you have to treat with antibiotics. If we found an abscess in how will we proceed? I think I have given the answer for that. Need to treat symptomatic bacteria, especially pregnancy. How do we identify? I will answer that later, that question. There is a question on that case history. So we'll answer that question when it comes. So, okay, so we'll resume with the presentation. Great. Case number 4. A 45-year-old man presents with frequency, urgency, and difficulty in passing urine associated with high fever. And acute bacterial prostatitis is suspected. So, as you know, that's one of the conditions that you need to suspect when somebody comes with frequency, urgency, and difficulty in passing urine. These are obstructive symptoms and irritative symptoms as well. You sometimes get them in benign prostatic hyperplasia, and especially a young person like 45-year-old man. Usually, you don't get benign, you don't expect to have benign prostatic hyperplasia in that age. If they come with these symptoms associated with fever, high fever, you have to think of one thing is whether there's a prostate infection. So the patient has been correctly suspected of having acute bacterial prostatitis. Which of the following statement is most appropriate in his management? So we'll start the poll. Case number 4. Okay. So you start entering your responses. Response A, coamoxiclav is a preferred antibiotic. B, antibiotic should be continued for 2 to 4 weeks. C, PSA or prostate specific antigen is not useful in the monitoring of response to treatment. D, TURP is a form of treatment. E, suprapubic catheterization is preferred over urethral catheterization if urine retention develops. By the way, TURP is a short form for transurethral resection of the prostate. Okay, I'll give you about 10 seconds to finish. Great, so we'll end the poll and I'll share the results. Okay, so majority of you think the answer is E. We'll see. So coamoxiclav is a preferred antibiotic is wrong because this patient has got a prostatitis. So one important thing about prostate is when prostate infection happens, it's the antibiotic, whatever that you're going to give, if the antibiotics to work, it has to reach the prostatic tissue. So again, like in pyelonephritis, sometimes not like pyelonephritis, prostate tissue, sometimes certain antibiotics don't penetrate into the prostate. But the good thing about that, good thing is that in the acute phase, when the prostate is very inflamed, most of the antibiotics do penetrate to the prostatic tissue. But however, once the inflammation subsides, these antibiotics no longer, certain antibiotics do not penetrate. So you need to, start with a drug that is usually penetrating to the into the prostate, and usually these are the fluoroquinolones, and usually ciprofloxacin, levofloxacin, and that category of drugs. And also cotrimoxazole is another drug which penetrates the prostate tissue. So those are the drugs that we usually give, and therefore coamoxiclav is not a preferred antibiotic, so it's wrong. B, antibiotic should be continued for 2 to 4 weeks. So one important thing about prostatic infection is that as I told you, the infection is very resistant to antibiotics. So therefore, you need to give a longer course of antibiotic, not like in any other urine tract infection. So I told you that in cystitis, usually you give about 3 to 5 days of oral antibiotics. If it's a complicated UTI, you give about 1 to 2 weeks of antibiotics. But when it comes to prostate infection, usually you have to give for 4 weeks of treatment, and sometimes it can go up to 6 weeks. So 4 to 6 weeks is the accepted answer. Therefore, B is not long enough. Although when you say 2 to 4 weeks, 4 weeks is included, but the 2 to 4 weeks period before that is not acceptable. So therefore, it is not correct. PSA is not useful. That is not correct, because prostate, when it is inflamed, it can give it increases the prostate specific antigen level in the blood. So that can be used to indicate an infection and also response to treatment. So once the prostate inflammation goes down, the PSA levels do improve. TURP is a form of treatment. Some have considered this as a possible answer, but what you need to understand, even in my initial presentation of the case, I told you that 45-year-old man very unlikely to have a prostate enlargement due to benign prostatic hyperplasia. So as we will discuss later, benign prostatic hyperplasia is a risk factor for developing prostatitis, but in this patient is very unlikely to have benign prostatic hyperplasia. Just prostatitis per se is not a reason for somebody to undergo a TURP. And the correct answer is, of course, C. And that is because sometimes when the prostate is acutely inflamed, doing urethral catheterization sometimes can harm or damage the urethral mucosa, especially involving the prostate when that particular area is inflamed, and sometimes that can lead to bacteremia and can give rise to septic shock. Therefore, sometimes it's better to use a suprapubic catheter to catheterize the patient in case of an acute retention of urine. So that is the correct answer. So we'll stop sharing. Right. So the correct answer is E. And just a bit of acute bacterial prostatitis. Usually, there are several certain risk factors that patient have, which can lead to acute bacterial prostatitis. These are, as I told you, presence of benign prostatic hypertrophy, presence of genitourinary infections, high-risk sexual behaviors, history of sexually transmitted diseases. So those are the high-risk groups that can develop this problem. And also immunocompromised state, phimosis, prostatic manipulation, especially in cystoscopy, transrectal prostate biopsies, urethral catheterizations. All these sometimes can lead to prostatitis, and also urethral strictures. So you need to suspect this in this group of people. And the organisms, commonly it is E. coli, as in simple cystitis, and but also you can think of other organisms, and also sometimes you can get uncommon organisms such as sexually transmitted organisms like Neisseria gonorrhoeae, Mycoplasma genitalium, Chlamydia trachomatis, and things like those infections which can cause urethritis also can be associated with prostatitis. So treatment, as I discussed in the case, it has to be with the drug which penetrates into the prostatic tissue, and it is either cotrimoxazole or a fluoroquinolone, and it should be continued for 4 to 6 weeks. Okay. Case number 5. A 65-year-old male with benign prostatic hyperplasia is admitted for transurethral resection of prostate. His UFR has 10 to 15 pus cells per high power field, and urine culture grows E. coli. He denies of any dysuria, frequency, or fever. Which of the following is most appropriate in his management? So we'll open the poll. Okay. So which of the following is most appropriate? Proceed with surgery as planned without any antibiotics. That is response A. Response B, proceed with surgery with antibiotic cover. C, to start an antibiotic only if a blood culture becomes positive. The last part is missing. D is to start a suitable antibiotic and postpone surgery until his urine culture becomes negative. Response E is to perform a prostatic biopsy to assess for bacterial prostatitis. So let's see how you fare. Okay, we'll stop. I think most of you have voted. Right. So I'll share the results. Okay. So majority have gone for either B or D. Right. So this patient has come for a routine surgery, which is a TURP, transurethral resection of prostate. And incidentally, the patient has been found to have a urine infection based on a urine culture. So this is called asymptomatic bacteriuria. So somebody has asked previously about a question about asymptomatic bacteriuria. So this is in a situation where patients are asymptomatic and their urine, which is being done for some other purposes, is found to have persistent or repeated positivity for organisms. So we'll discuss about it in detail later. But usually when there is asymptomatic bacteriuria, you don't need to treat because patient is asymptomatic, and therefore even though the organisms are there in the urine, it is not going to cause any problems to the patient. So we don't need to treat, except in two situations. One is where the patient is pregnant. So if a patient is pregnant and has got a urine infection, even if the patient is asymptomatic, we need to treat the infection, because if not, the patient can develop maternal as well as fetal complications. So maternal complications is that the patient is a high chance of developing acute pyelonephritis. So that is the maternal complication. The fetal complications are more. These are premature rupture of membranes, intrauterine growth retardation, and chorioamnitis and things like that. So therefore, this patient should be treated if the patient is pregnant, even if there are no symptoms. That is why in obstetric clinics, from the time of the booking visit, every female periodically has to do urine cultures. The other situation where you need to give antibiotics despite patient being symptomatic, if you are doing a urological procedure. In this situation, especially invasive urological procedures where there's a chance that you can damage the urothelium so that the organisms can enter the bloodstream and cause septicemia. So that is what this patient is at a risk, because the patient is going for a transurethral resection of prostate. So proceeding with the surgery as planned without any antibiotic is incorrect. Proceed with surgery with antibiotic cover is a possible option. Starting antibiotics only if blood culture becomes positive is not relevant, because patients already got a urine infection, and I told you why you need to start antibiotics in this situation. So C is also incorrect. Start a suitable antibiotic and postpone surgery until his urine culture becomes negative. So E, perform a prostatic biopsy to assess for bacterial prostatitis is not really indicated in this situation, and it can be even harmful because you are going to do a prostatic biopsy that might lead to dissemination of the infection into the prostatic tissue and can cause actual prostatitis even if the patient doesn't have it. So E, C, and A are obviously wrong. So the answer is between B and D. So here both seem to be correct, but what you need to understand is this is not an emergency surgery, and the patient is quite well, and you don't need to rush for the surgery. You can always treat and then see whether the culture is negative and then go for surgery, rather than going with surgery with antibiotic cover, because sometimes you might not know which antibiotics, whether the antibiotic whether it will work, and all these things, and if at all there's a chance of these organisms getting into the bloodstream. So unless if there's a life-threatening situation where the patient needs emergency surgery, generally it's not recommended to go for surgery in the presence of an infection. So the correct answer is D. So we'll stop sharing. Right. Yeah. So just a bit of asymptomatic bacteria. So as I told you, what is asymptomatic bacteria? It is where you get repeated cultures positive despite the patient being not symptomatic, and usually the treatment is only indicated in two situations, where whether the patient is pregnant, or if there is a urological procedure planned. So that is the only thing you need to remember. Right, last case. So after this, we'll give opportunity for another session of question and answer session. So case number 6, a 54-year-old postmenopausal female presents with a culture positive E. coli symptomatic cystitis. So it's a symptomatic cystitis in a postmenopausal female, and the culture has grown E. coli. So it's a confirmed case. She has been successfully treated with norfloxacin for a cystitis with the same organism 4 weeks back. So 4 weeks ago, she has had a similar infection with the same organism and is successfully treated with norfloxacin. With regard to her management, which is the correct response? So I will open the poll now. Right. Her infection is likely to be a result of a relapse. B, it is best treated with another cause of norfloxacin. C, an ultrasound scan KOB is likely to help in the further management. Management is missing here, so it's for the further management. She should be started on antibiotic prophylaxis after treating this episode. E, use of intravaginal estrogens is likely to reduce further episodes of urinary tract infections. Okay, 10 more seconds. Right, so we'll stop there. Yeah, okay, so there's a wide distribution of responses. Okay, so let's discuss the case. So this is a situation where the patient has developed recurrent urinary tract infection. So what you mean by recurrent urinary tract infection is that where the patient develops, we'll discuss it later with some more slides, but where the patient keeps on getting infections, urine tract infection. These are called recurrent UTI, urine tract infection. So here the patient has had a similar UTI 4 weeks ago with the same organism and been treated. So the first response is her infection is likely to be a result of relapse. So you need to know what is a relapse and what is a reinfection. So relapse is where the infection has not really gone away with the antibiotic, and the infection organism is not totally eradicated. And the same organism gets subdued with the course of antibiotic, and it recurs after some time. So it's very difficult to say, whereas a reinfection is where the initial organism is cured with the antibiotic, but the patient gets reinfected with the same or a different organism later on. So sometimes it's very difficult to differentiate whether it's a relapse or a reinfection, but there are certain criteria that we use. One thing is, if the infection occurs within 2 weeks of completion of the antibiotics, then it's more likely to be a relapse. Whereas if the infection occurs after 2 weeks of completion of the antibiotic, it's more likely to be a reinfection, even if it's the same organism. So here, the patient has had treated for a cystitis 4 weeks ago, and has now come with another infection. So it is more likely to be a reinfection rather than a relapse. Whereas in a relapse, you would expect the patient to get a infection much more earlier than this, within 2 weeks. So therefore, as for that matter, most of the infections, recurrent infections, most of the infections in recurrent infections is actually due to reinfection, because these flora, the organisms tend to colonize these perineal region of these females, and even if the initial infection gets cured, again these bacteria tend to again go into the urinary tract, because the organism is colonizing the perineal region. So it's a reinfection. So most of them are reinfections. So in this case, A is incorrect. It is best treated with another course of norfloxacin. So again, it's a bit controversial, because obviously the patient has been previously treated with norfloxacin. Being the same organism, it's more likely to be sensitive to the antibiotic because of that. But there again, repeatedly using the same antibiotic can cause resistance in these patients, because, as you know, these bacteria are colonizing the urogenital tract. So therefore, best treatment is to use the same antibiotic, I would say, is probably not correct. Third response is ultrasound scan KUB. Majority of you all have selected that answer. But it's important to realize that majority of the patients in this age group, post-menopausal females, either in the perimenopausal period or post-menopausal period, 54 years is not that old, in that group, especially if they don't have other risk factors like any neurological problems or any diabetes and things like that, ultrasound scan KUB is unlikely to be useful, because they don't usually have any anatomical problems. And the most important thing you think of when somebody has recurrent urinary tract infection is whether they have obstructions in the urinary tract, or whether they have impaired emptying of the bladder, leading to retention of urine and things like that. So all that can be detected by doing an ultrasound scan. but studies have shown that in this particular age group, intermediate postmenopausal group, ultrasound scans are not that useful because most of them don't have any such abnormalities. So, so then we need to find out why they are getting urinary tract infections recurrent. Before that, response D, whether she should be started on antibiotic prophylaxis. Again, another controversial thing about recurrent UTIs is whether you want to put them on prophylactic antibiotics, whether you want to put everybody on prophylactic antibiotics. So just because somebody has got recurrent UTIs doesn't mean that you should put them on antibiotic prophylaxis, because if that is not interfering their usual lifestyle, if it is not compromising their day-to-day function or going to work or their sleep and things like that, just getting a UTI, recurrent UTI, doesn't mean that you need to put them on daily prophylaxis, because if they are okay, they're happy to just get a short course of antibiotics and treat every time they get the infection. You don't really need to put them on prophylactic antibiotics. So it all depends on how much they are compromised by getting recurrent urinary tract infections. For example, if they are getting complicated UTIs, pyelonephritis recurrently, repeatedly, and they are interfering with their work and other things, then of course you need to consider prophylactic antibiotic. But there's blanketly you don't put everybody on prophylactic antibiotic just because they have recurrent UTIs. And the final response is the correct answer. So these females who are in the postmenopausal kind of time period, they kind of have reduced level of estrogens in their system. So that becomes not a very conducive environment for the commensals, because of the estrogens in the lack of estrogens in the perineal region and the vaginal area. And therefore the commensals tend to get they die because of lack of estrogen, and because of that the pathogens can colonize the vaginal and the perineal region. So that is why they tend to get more infections. So therefore intravaginal estrogen use has been shown to allow colonize these epithelia with commensals, making it less susceptible to colonization with pathogenic flora. So that is why E is correct is the correct answer. So I will so that is the correct answer. So we'll stop sharing. Yeah, so a little bit about recurrent UTIs. So as I told you, recurrent UTIs, there's a definition. So either you have to have 2 or more infections per 6 months or 3 or more per year. So that is why when you call them having recurrent infections. Relapse is, so as I told you, the difference between relapse and reinfection is this 2-week period. If it happens within 2 weeks of completion of antibiotics, more likely to be a relapse. Whereas reinfection, even if it is with the same organism, if it happens after 2 weeks, it's called a reinfection. So it's important to educate or manage these patients with recurrent UTIs. And one important, there are several non-pharmacological measures you can use. One thing is to ensure that they drink a lot of fluid, because that helps to flush the organisms, pathogens out, so that and it's been shown in studies that asking them to drink more water has been shown to reduce the episodes of infections. And also certain females use certain contraceptives with spermicides, and these are harmful for the the commensal bacteria in these urogenital epithelium, and so therefore you should avoid using them. And as I told you, sexual intercourse is one of the main risk factors why females in sexually active age group get urinary tract infections, and one way to avoid this is by asking them to do postcoital voiding. So after intercourse, they have to go to the washroom and empty the bladder. That will that has also been shown to reduce the infection rates. And also make sure you ensure good hygiene in the perineal region. And as the last one, as I told you, the using topical estrogen for postmenopausal women has been shown to reduce recurrent UTIs. And the pharmacological management, as I told you, not everybody will need prophylactic antibiotics, but once we know that we need to give them, especially if they are compromised by the repeated infections, you can give prophylactic antibiotics. Usually you give low dose antibiotics as a daily treatment. You can use trimethoprim sulfamethoxazole, with this cotrimazole, or you can use nitrofurantoin, you can use cefalexin or ciprofloxacin, norfloxacin. So there are other drugs also, but these are some of the common ones that we use. And also sometimes, especially if the infection is related to their sexual activities, you can use post-coital prophylaxis, where any of these drugs, rather than taking daily, you can ask them to take after sexual intercourse. Every time they do that, they take the antibiotic, and that is helpful in preventing infection. So so that is it. So I think we have come to the end of the presentation. Right. So if you have any other questions, you can now ask. So there are some questions which has come already. So we'll start answering them. Right. Yeah. Yeah. And don't try to draw things on the screen, because it makes it difficult for me to read all these questions. So can UTI cause meningitis, methicillin resistant Staph aureus? It's not a very common cause for meningitis. But if you get bacteremia, there is a chance that you can get, but it's not a very common association. If a male comes with dysuria for 2 days without fever and loin pain, do we still treat it as a complicated UTI? So again, this is a problem with classification. Whether somebody has got a complicated UTI or a non-complicated UTI is based on which book you read. So what you need to remember is whether, rather than going by these definitions, if somebody has got abnormal urinary tract, or has got any risk factors to develop complications, or problems, poor response to treatment and things like that, if those are there, then that is called a complicated UTI. So if a male without any other risk factors, who has no features of upper tract involvement, if they just come with a cystitis, I would just consider it just as a female getting a similar episode, as a simple thing. But again, you might be asked, if somebody might say that's a complicated UTI, but it doesn't really matter. The management, if it differs in the management only, you will have to worry. So I would just treat a male with dysuria without any other things as same as a female of the same category. So I would consider it as just a simple UTI. If a kidney transplant patient develops asymptomatic bacteriuria, do we need to treat him? Again, it's a good question, but as I told you, there are only 2 groups where we need to treat asymptomatic bacteria, and kidney transplant patients was not given in that group, 2 groups. So that same principle applies. Even if a kidney transplant patient comes with the asymptomatic bacteriuria, you don't need to treat. In a male, urethritis is a lower urine tract or sexually transmitted infection. So again, this is again talking about classification. So urethritis is inflammation of the urethra. So as I told you, in my classification nomenclature, lower urinary tract infection is urethra in the lower urinary tract, yes. So if it is caused by infection in the urethra, if it is in the lower urinary tract, urethritis is a lower urinary tract infection. So nobody can argue against that. At the same time, it is a sexually transmitted infection. It could be, because some of these organisms can be sexually transmitted. So it can be both a lower urinary tract infection as well as a sexually transmitted infection. It doesn't have to be mutually exclusive. The next question is, does long-term prophylaxis lead to antibiotic resistance? Yes. So that is one of the main issues why we don't want to put everybody on long-term antibiotic prophylaxis, because these organisms, as I told you, are colonized. Pathogens are there in the perineal region of these patients. So they are constantly being exposed to these prophylactic antibiotics. There is a chance that they end up getting resistance. So there are various ways that we can use to minimize antibiotic resistance. One is to minimize using prophylactic antibiotics unless it's really indicated. And the next thing is use different antibiotics cyclically. So you can use one antibiotic for one particular month and then change it to a different antibiotic. These are some of the methods that you can use, but I don't know whether it actually makes a difference in the end. In case 6, if the patient is presented with asymptomatic bacteria with the same organism, do we treat? No. So I told you that asymptomatic bacteria treatment is only indicated for 2 situations, which I have already discussed. What are the reasons for fungal UTIs in immunocompetent patient? Commonly it comes because when you are on long courses of antibiotics, because again, when usually the normal flora in the urogenital tract does not allow the pathogens to grow. So if the normal flora gets compromised, especially when you're on long courses of antibiotics for some other thing, sometimes they can get fungal infection. So that is one situation. Other situation is if they are on long-term catheterization and things like that. Also, even if they are immunocompetent, you can get fungal infections. Wouldn't doing surgery with antibiotic cover help to reduce the stasis and speed up the recovery? Yeah, that's again a good question. Question, but the thing is, I didn't say there is a stasis. Just because somebody has got benign prostatic hyperplasia doesn't mean all of them have got stasis. In other words, what is meant by stasis is when you evacuate the bladder, when you pass urine, you don't completely empty the bladder. There's some volume of urine left behind. So that is a risk factor for UTI, as correctly this particular student is mentioning. But there again, not all patients with benign prostatic hyperplasia will develop residual urine. And also that may not be the reason why the patient wants surgery. It may be just because they have symptoms. So therefore, in this situation, we don't really know whether there is stasis of urine or not. So therefore, we can't make that as a reason for expediting the surgery. And I mean, generally, when we say giving antibiotics and checking for recovery, you don't go for months. You just give a course of antibiotic for about a week and then do the culture. So maximum it will be delayed by about 2 weeks. So that's not going to make much of a difference anyway. Is asymptomatic bacteriuria treated in patients with a solitary functioning kidney? No. Again, you all are asking again and again different situations, but I told you that only 2 situations where we treat asymptomatic bacteria, and that doesn't change just because there are other situations, right? What is prostatic massage and get samples? So sometimes when you get a prostate infection, you need to get the prostatic material to confirm the diagnosis, because the infection is in the prostate. Like in the cystitis, you take urine. So likewise, but so there was this recommendation that you can do a massage of the prostate and extract the prostatic secretions into the urethra and collect them for sampling, but it's not no longer recommended because especially when the prostate is so inflamed, doing prostatic massage can sometimes lead to dissemination of the infection and cause septicemia and septic shock. So therefore it's no longer, it's very uncomfortable for somebody having a tender prostate to go for prostatic massage. So it's no longer a recommended method of getting samples from the prostate. If male develops chronic prostatitis, do we turn or treat with UTI with antibiotics? Yeah, I think chronic prostatitis I didn't mention. One of the risk factors for one of the issues with acute bacterial prostatitis, they can end up with chronic prostatitis if the infection doesn't settle, and that it becomes a very long-term process. And I don't think you need to worry too much about that. That's a more specialized topic, and sometimes you might need longer courses of antibiotics, even IV antibiotics, and sometimes you might need prosthetic surgery. So it's, don't worry too much about that. It's a more specialized area. I think there are so many questions. I think we'll just run through. I don't put any more questions. Ciprofloxacin is reserved for drug for TB. Does it good to treat UTIs? You know that is true, but that's why I said Cipro. More than Cipro, you try to treat with things like nitrofurantoid. But sometimes ciprofloxacin is one of the best drugs to treat for UTIs, and is commonly used. And it's a second line drug for TB. So I don't think we should really restrict too much use of Cipro. Can recurrent cystitis affect kidney function? No. Usually upper tract involvement is the one which affects kidney function, whereas your recurrent cystitis doesn't usually cause kidney injury. From where can we read these management guidelines? I think you can read any medical textbook. So the common ones you have is Kumar and Clark, and other medical books that you are reading. I think they will all have a segment on treatment of urinary tract infection. So you can read one of those. If a younger male coming with first episode of UTI with culture result E. coli, can we go straight to screen for STD? I don't see the relevance of E. coli and STD. I don't understand because they are two different things. In case of patient presenting fever, loin pain, do we need to do urgent ultrasound scan to exclude obstructed system? No, because as I told you, fever, loin pain is just an indication that the patient has pyelonephritis. So most of them don't have obstruction. So if you start treatment and then if the patient has poor response to treatment only, you have to consider imaging. But there again, there's no harm in doing an imaging, because sometimes you can have underlying anatomical problems which might be recognized by ultrasound imaging. But what I told was, in the case scenario, it is not to detect underlying cause, it is to confirm the diagnosis. You don't need ultrasound to confirm pyelonephritis. So don't mix up those things. If a person with hemiparesis develop recurrent UTI, is it advisable to start prophylaxis? So hemiparesis doesn't mean anything. What you are trying to say is, when somebody has got a stroke, probably with some bladder dysfunction, whether that will be, if they have recurrent UTIs, whether is it advisable to start prophylaxis? Again, it all depends on how bad the recurrence is. If the patient gets severe, symptomatic UTIs and fever, pyelonephritis, and complications, then yes. But if the patient just has a urine infection without much symptoms or complications, then you don't need to give prophylaxis. Will recurrent UTIs in CKD patients need prophylaxis? Will they recurrent UTI worsen the CKD? Again, the answer is depends on where the infection is. If the infection is just in the bladder, it does not cause further kidney damage. Whereas if it is pyelonephritis, yes, it can cause kidney damage. I think that is it. So what I will do is, I will get these slides sent to you, all three lectures I did. And of course, all of these lectures all three will be available in the LMS for you to go through again, because some of these information I've not included in the slides. So you might have to go through this again and again to get some of the content into your head. Okay, so good luck with your exams, and we will meet you in when you come to clinicals next year. Good. Okay.